يسعدنا ويشرفنا ان معانا الدكتوره سمر السويلم من السعوديه وكضيفه على المؤتمر، واحنا سعداء ان هي معانا في السيشن. هي هنبدا بقى نعمل توتال شيفت، هنتكلم على الفيك اي او الز او الاي سي الز. دايما بنقول في اوقات كده نقول سيب الكورنيا في حالها، يعني بلاش، خلينا نخش على حاجه تانية. فهي هتكلمنا على الوين اي سي ال شيفت predictors pitfalls and long term lessons. اتفضلي يا دكتوره سمر.
Assalamu alaikum. Good morning, everyone. So, as a refractive surgeons, we always share our successful stories, but we never shared our failures. And this presentation, I would like to show some failures of the ICL's procedures cases. So my name is Samar Al Swailem. I'm from King Khalid Eye Specialist Hospital, and I'm delighted really to share my experience with you. Um, as an ICL surgeon since the FDA approval of ICL since 2008, as I said earlier, I had many successful and safe procedures, and the low complication rates that we had even expanded our indications. Nowadays, we're doing it even for keratoconus routinely back home. However, there are some failure cases that worth, shedding a light on and disseminating a knowledge. And this is why I'm standing here in front of you. So that failure could be related to an external insult, in particular related to a trauma or to an internal flu. Mainly, we're talking about the anatomical. Now, the first case belonged to a patient who's a 27-year-old, 5 years post a successful ICL that resulted in a 2025 best vision. He sustained a trauma by a fast. He's a gentleman, and he presented to the emergency room 3 days following the trauma with the key diagnostic signs of ICL subluxation into the anterior chamber. As you can see here, the foot blade is really dislocated, even not subluxated, because you can see it on the top of the iris itself. So it's not only just a gentle movement, it's a major shift of the ICL and foot blade. Now, the initial examination confirmed drop in his vision, and the optical OCT also showed clearly the foot plate on the top. Now, the foot plate was not touching the endothelium, but the patient underwent an urgent ICL repositioning on the same day, and after a few hours following marking of his corneal axis, and luckily his vision improved back again to 2025 and until today, and he had no complications. And the second patient sustained a trauma by a football, and his surgery was done because of post keratoplasty astigmatism, and it was 7 years earlier, and his vision was really good 2025 prior to the trauma. And I know that all of us are excited about the FIFA World Cup, and I would really wish all the best for all the Arab countries participating. But also, we always encourage our patients and advise them about being careful with the trauma from the footballs. Now, his vision dropped from 2025 to 2030, and he had actually a mild anterior chamber reaction, a peak pupil, as you can see here. Sometimes it's really difficult to highlight, especially if the pupil is a little bit in mid-dilated position, and he underwent again an urgent repositioning under topical anesthesia, and his follow-up up to 4 years revealed a vision of 2020 and still clear cornea. Now, in the whole literature, there are only 5 cases of a trauma, despite doing thousands of cases worldwide. Only few reported cases of a trauma, and we added to them too. The good thing is that, as you notice, most of the patients underwent a successful repositioning and they gained a good vision, with the exceptions of those who one case only that had two major quadrants of zonular dialysis and even shift of the ICL back. In a few years ago, before even the era of ICL, we witnessed some of these phakic IOLs going into the back because of their poor design. ICL is not meant to go to the back unless it's really very bad trauma. So actually, it's the trauma is not the enemy. It's about early recognition of the trauma, and that's why we always advocate our fellows and encourage them to check really for the position of ICL for any patients who presents following trauma. Now, it can happen at any time, even years after surgery, as you see in our two cases. The important is to detect clinically and to act fast and to prevent and educate the patients. Now, another case is totally different from this trauma. Presented to us, he's a 27 years. He's a marfanoid. He has marfanoid body habitus, not a marfan, but etamarfanoid with some features. And he had a contact lens intolerance. He was wearing it in one eye because of anisometropia. In that eye, his vision was 2200, was the right eye, and his best vision was reaching up to 2030. Okay, so we had -2, -5.5, axis 15. Back home, we had a quite good number of cases with a thin cornea, and every time we encouraged them to go for the BRK with the cross-linking, they were hesitant because of the risks of ectasia, which is very high in Saudi, and we don't have a toric artisan. Yes, we do have artisan, but not the toric design, and the patient was reading a lot about the ICL and was motivated to have it. So we, with all the risks and benefits, he underwent it. And then the good thing is that I want to forget to mention also that he had a coloboma. Now that coloboma, as you can see here, was a very small, from 5 to 7 o'clock, and the ICL was implanted with 10-degree shift counterclockwise, so it was really away from his coloboma. In the first visit, his fold was okay, only half corneal thickness. He achieved 20/40 vision. However, 3 weeks later, his vision was 20/80. And as you can see here, this is his ICL. It's really sinking in the sulcus. And because of that, the patient had underwent an immediate, explantation of the ICL. Now, on the same day of the presentations, we've done for the patients and routine imaging, the OCT and UPM, and surprised to found a ciliary body cyst as something that we don't usually look for, but it contributes to the shift of the ICLs in those patients, and keep in mind. So it's the ICL wasn't the wrong device in this patient particular, but the eye was the wrong candidate, right? And especially because of the zonular weakness in marfanoid patients and presence of the ciliary cyst in this patient. So I would say that it should be, one of the contraindication for this. Now, if we talk about the coloboma by itself, we know that the lens coloboma is not an absolute contraindication if it is less than 1 quadrant away from the implantation axis. But if it is more than 2 quadrants with the severe, zonular weakness, we won't advise to have an ICL implantation. So back again to the same table, the external insult versus internal. You can see that trauma can happen at any time, but coloboma always shifting the ICLs earlier, and it's really predictable in the trauma, but it's not predictable, in trauma, but it's predictable in the coloboma. So the treatment is obvious to both, category, and the failure is always the end results in patients with coloboma. So we have some diagnostic red flags criteria. Which patients you want to do them is that any patients who have, a history of ocular trauma, you need really to subject the patients to an imaging. Patients who have a systemic, connective tissue disease like a marfanoid, patients, it's advised always to have an imaging. Patients, can I have 1 minute, please? Yeah, and patients who have a lenticular iris coloboma and presence of iridodonesis is important. And I would say that it's always advisable to dilate the pupil fully maximum in order to even evaluate the extent of the coloboma if you find it, and they even find iridodonesis. Patients with high myope, look into the OCT macula and the potential visual acuity. The slides. Patient education is a lifelong commitment for all of us. So counseling is not only for the risks and benefits, but also for the future risks of trauma and the shifts of these ICLs and presentations to the emergency. We always teach our fellows and residents to look carefully for all the signs, as I mentioned. So the medicine is really a science of uncertainty, and it's an art of probability. And it's our job as as a physician to practice that art of judgment and to implant the best devices in our patients and to weigh the risks and benefits. There are a lot of probabilistic decisions in our routine life, and one of it is this refractive procedure. So it's really and it can be a successful procedure only if we implant it in the right eye and select the right patients. And I would like to thank you for your kind attention and acknowledge my co-authors and invite you to our next coming Saudi Cornea and Refractive Surgery Association conference that will take place prior to Ramadan next year.
Thank you, Dr. Samar, for this nice presentation.